Welcome to the deep dive. Today, we're getting into a really critical area of medicine.
Yeah, we're looking at pharmacotherapy for some unique groups, kids, pregnant individuals, and lactating mothers.
Right. We're basically trying to build a safety framework where maybe one didn't always exist.
Exactly.
Uh,
Because, for too long, the thinking was, oh, a child is just a small adult. And that idea, it's not just wrong, it's dangerous.
it's led to actual tragedies, hasn't it?
It has. We have historical examples that really drive this home. You have to look back at the chloramphenicol issue in the 60s.
Gray baby syndrome.
That's the one. Neonates got it. Their livers just couldn't metabolize the drug properly. It built up toxic levels, resulting in circulatory collapse, shock, death.
Because the enzymes weren't developed?
Precisely. The infant liver just wasn't mature enough.
And it wasn't just internal issues, right? Even the skin barrier was different. Hexachlorophene.
Yeah, hexachlorophene in the 70s seemed routine, fine for adults, but bathing premature babies in it?
What happened?
It led to vascular encephalopathy, basically brain swelling. It proved their skin is immature, huge surface area relative to weight, massive absorption.
Okay, so the small adult model is clearly out. We need a better approach. Our sources talk about 4 core concepts.
Yeah, like a checklist for safe therapy. First is physiological variability, ADME. Absorption, distribution, metabolism, excretion. How these change with age or pregnancy.
Okay, ADME variability. What's second?
Second, you have to consider the drug's effects on long-term growth and development, not just immediate effects.
Third, the placental-fetal unit, that barrier.
Crucial. What gets across, what doesn't. And finally, number 4, think about underlying diseases, how they affect the drug, how the drug affects them.
It's a lot to juggle, which
Yeah.
probably explains why getting pediatric drug data was so hard historically.
Definitely. Manufacturers were hesitant. Clinical trials are expensive, complex.
But legislation has stepped in. Things like BPCA, PREA.
Right. The Best Pharmaceuticals for Children Act and the Pediatric Research Equity Act. They basically mandate or incentivize studies for drugs likely used in kids, trying to fill that data gap.
Okay, let's tackle that variability. You mentioned the pediatric pharmacokinetic roller coaster, starting with A, absorption. Neonates have alkaline stomachs, not acidic.
Yeah, for about the first month, their stomach pH is higher, less acidic. And this completely flips the script for some drugs.
How so?
Well, drugs need a certain charge state to cross membranes. In that less acidic environment, weakly acidic drugs like phenobarbital become more ionized.
Ionized means polar, right? Harder to absorb.
Exactly. So absorption goes down. But counterintuitively, weakly basic drugs, they actually get absorbed better.
Huh. Okay. And there are physical factors, too, like stomach emptying.
Right. Gastric emptying is delayed in neonates. Peristalsis is irregular. It all makes absorption pretty erratic sometimes.
And the skin, we touched on hexachlorophene. Why is that percutaneous absorption so much higher?
It really boils down to 2 things. Surface area and barrier function. Their outer skin layer, the stratum corneum, it's much thinner.
Less protective.
Right. And they have a huge skin surface area compared to their body mass. So put something like salicylic acid ointment on them.
It could get absorbed systemically, lead to toxicity.
That's the risk. Yeah. High potency steroids too.
Okay, moving to D distribution. Water content is key here. Neonates are like 75–80% water.
Much higher than adults who are around 60%. And this high water content means a larger volume of distribution, the VD, for water-soluble drugs.
So the drug spreads out more.
It does, which means, and this surprises people, you often need a larger dose per kilo for water-soluble drugs. Think aminoglycosides.
A larger mg/kd dose for an infant than an adult.
Often, yes, to get the same therapeutic concentration.
What about proteins, plasma protein binding? Neonates have less albumin.
Correct. Less albumin and also less alpha-1 acid glycoprotein. This means less capacity to bind drugs that usually stick to these proteins.
Which leaves more free drug.
Exactly. And free drug is active drug. Too much free drug equals higher risk of toxicity. Phenytoin is a good example here again. Higher free fraction, more risk.
Okay, M&E, metabolism and elimination. The maturation clock. Phase IN2 reactions are delayed.
Yeah, the enzyme systems, particularly in the liver, they're just not fully operational at birth. This includes the P450 cytochrome system, or CYP enzymes.
And there's a huge safety issue with one specific CYP enzyme, CYP2D6.
A critical one. Some people are genetically ultra-rapid metabolizers, via CYP2D6. This enzyme activates certain pain meds, like codeine and tramadol.
It turns them into morphine, right?
Turns them into morphine or other potent metabolites very quickly. So an ultra-rapid metabolizer kid gets a standard dose.
And they essentially overdose themselves.
Yes, they generate huge levels fast, leading to severe respiratory depression, even death. That's why there's an FDA-boxed warning now.
Restricting codeine and tramadol in kids under 12.
Right. And cautioning use in breastfeeding mothers, too, because the active drug can pass into the milk and affect the baby. Sleepiness, breathing problems.
Very important. Okay, finally, elimination. The kidneys. How long until they're up to speed?
Well, the GFR, the glomerular filtration rate, that's the filtering capacity. It doesn't really reach adult levels until around age 2.
Age 2, what?
And tubular secretion, which also helps to clear drugs, that can lag until 5 to 7 months.
So what does this renal immaturity mean for dosing?
It means the half-life of drugs cleared by the kidneys is much longer. Things like aminoglycosides, again, penicillins, sulfonamides, they stick around longer.
So you need longer dosing intervals, give the drug less frequently.
Exactly. Longer intervals are key to prevent accumulation and toxicity.
Okay, let's shift gears now. Section 2. Pregnancy. It's another area of huge physiological change.
Right. The maternal body undergoes massive adaptations. How does this impact pharmacokinetics, the ADME?
Well, first, there's a big increase in total body water, up to 8 liters more. Plus, cardiac output goes way up.
So just like the neonate, a larger volume of distribution. Yep. Especially for water-soluble drugs. They get diluted, effectively, sometimes requiring higher doses to maintain therapeutic levels.
But the kidneys go into overdrive.
I really do. GFR can jump by 50% or even more. This means faster clearance for drugs eliminated by the kidneys.
Like ciprofloxacin.
Ciprofloxacin is a good example. Its clearance speeds up significantly. For some drugs, like lamotrigine for seizures or indinavir for HIV, this increased clearance is so significant you actually need therapeutic drug monitoring.
To make sure the levels don't drop too low.
Precisely. To avoid undertreatment.
Okay, what about getting drugs to the fetus?
Right.
Placental transfer. What factors determine if a drug crosses over?
It mainly comes down to 3 things. High lipid solubility fat-loving drugs cross easily. Small molecular weight tiny drugs slip through. And low protein binding.
So small, fatty drugs are most likely to cross.
Generally, yes. Molecules under about 500 grams per mole cross readily. Think acetaminophen crosses easily. Big molecules like heparin or insulin, they're mostly blocked.
Does the placenta fight back? Does it have defenses?
It does. A key one is P-glycoprotein, PGP. It's an active transporter pump.
What does it do?
It actively pumps many drugs back out of the placental cells into the mother's blood. It's a protective barrier.
So the danger is if the mother takes a drug that inhibits PGP.
Exactly. That disables the pump, potentially letting harmful drugs get through to the fetus.
And fetal risk isn't uniform throughout pregnancy, right? When is the period of highest risk for teratogenicity, for birth defects?
The first couple of weeks after conception, there's some protection. The cells are to potential. They can often replace damaged ones. But the really high-risk window is the first trimester, the first 3 months.
That's when organs are forming, organogenesis.
Exactly. That's when drugs are most likely to cause major structural abnormalities. Extreme caution is needed then.
But risks exist later, too, like aspirin late in pregnancy.
Yes. Aspirin late term can increase bleeding risk for mother and baby and potentially delay labor.
Got it. And assessing this risk used to involve those letter categories A, B, C, D, X.
Which were, frankly, confusing and often misinterpreted. A C drug could mean anything from limited data to known animal risks.
So the FDA changed it.
Yes, to the Pregnancy and Lactation Labeling Rule, the PLLR. It got rid of the letters.
What does it require instead?
It mandates 3 detailed sections on the drug label: pregnancy, lactation, and females, males of reproductive potential. Each needs a risk summary, clinical considerations, and actual data supporting it. It's much more informative. Like an essay, not just a grade.
Okay, let's move into lactation. How do drugs get into breast milk? Similar factors.
Pretty similar, yeah. Good blood flow to the breast tissue is needed. The fat content of the milk matters lipophilic. Fat-loving drugs tend to concentrate there. And again, smaller molecular weight, higher lipophilicity favor transfer.
So for a breastfeeding mother who needs medication, what's the best way to minimize the baby's exposure? Any clinical pearls?
Well, ideally you choose drugs with short half-lives and ones with low oral bioavailability in the infant, meaning even if it gets in the milk, the baby won't absorb much.
But the key strategy involves timing.
Timing is everything. The absolute best strategy is for the mother to take her medication immediately after breastfeeding,
Why then?
because drug levels in the milk usually peak around the same time as in the mother's blood. Taking it right after feeding means levels will be lowest by the time the next feeding comes around.
That makes sense. And if clinicians need specific info on a drug during lactation, is there a go-to resource?
Absolutely. LactMed. It's a database from the National Library of Medicine. It's kept up to date, gives data on drug levels in milk, potential infant effects, suggested alternatives. It's the standard reference.
Okay, circling back quickly to pediatric dosing itself, we usually use weight, mg/kg per day. When would body surface area, BSA, be used instead?
BSA is usually reserved for very specific situations, mainly anti-neoplastics, chemotherapy drugs, or sometimes in critically ill kids.
Why BSA for those?
It's thought to correlate a bit better with things like metabolic rate, GFR, cardiac output, which are crucial for those high-risk drugs.
And with childhood obesity being more common, how do we handle dosing for heavier kids? Is there a cap?
There is. You generally use weight-based dosing, the mg/kg calculation, up to a weight of 40 kilograms.
And after 40 kilograms?
For any child over 40 kilos, you typically cap the dose at the standard recommended adult dose for that specific indication. You should never exceed the maximum adult dose, even if the mg/kg calculation comes out higher.
That's a critical safety check. Okay, last bit on PEDS. Administration. Liquid meds for infants. How should they be given?
Always. Always use a proper oral syringe, not a cup or spoon. Place the tip in the side of the mouth between the cheek and gum. Administer slowly to allow swallowing.
And the big don't. Never mix it with.
Never mix medication into a full bottle of formula or milk. Big risk.
Why is that so bad?
2 reasons. 1, the baby doesn't finish the whole bottle. They don't get the full dose, underdosing. 2, you risk drug-nutrient interactions. Phenytoin, for example, binds to components in enteral feeds, reducing its absorption.
Got it. Use an oral syringe, aim for the cheek, and never mix in the bottle. What about injections? Any way to make those less painful?
Yeah, there are strategies. The sources mention things like topical anesthetics, lidocaine needle-free systems, vapor-coolant sprays. Table 4.6 in the source has a list. Minimizing pain is important. So wrapping this all together, we have to talk about medication errors. The risk is just higher in pediatrics.
How much higher?
The Joint Commission points out that harm from med errors is actually 3 times greater in kids compared to adults.
3 times? That's sobering. It really emphasizes the need for solid prevention strategies. What do groups like the AAP recommend? Box 4.1 in the source.
They focus on standardization and clarity to reduce ambiguity. Key things include: always confirm the patient's weight and BSA are current and accurate.
Makes sense. What else?
How you write doses. Always use a leading zero before a decimal point. Write 0.5 milligrams, not 0.5 milligrams.
Savent's reading it as 5 milligrams.
Exactly. And never use a trailing zero after old number. Write 1 milligram, not 1.0 milligram.
Savent's reading it as 10 milligram.
Right. Those zeros are crucial. Also, standardized concentrations for high alert meds like heparin, insulin. Don't have multiple different strengths floating around if you can avoid it.
And use oral syringes for liquids, as we said.
These are system-level checks to build in safety because the margin for error is just so small with these patients.
So the recurring theme here, the constant challenge, is that balancing act, weighing the benefit to the mother or child against the risk of drug exposure.
It really is. And it's crucial to remember that not treating the mother's condition can also pose huge risks to the fetus or the child.
Right. Untreated epilepsy or severe hypertension during pregnancy.
Those carry major risks that often outweigh the potential risks of a carefully chosen and monitored medication. It's never a simple decision.
This has been a really insightful deep dive. It hammers home just how specialized this area is. Physiological variability is the key driver, demanding unique dosing, specific formulations, and robust safety systems.
Absolutely. And as you're learning these principles, maybe one final thought to carry with you. It's about the long game.
Okay.
We understandably focus a lot on the immediate, acute adverse effects. Gray baby syndrome, respiratory depression, things we see quickly.
Sure.
But the true impact, the full risk profile of many drugs used in pregnancy or childhood might not show up for years, even decades.
Like what?
Think about things like secondary cancers potentially linked to chemotherapy given decades earlier. Or subtle effects like inhaled steroids, possibly having a small impact on final adult height.
Wow. So the story isn't over when the treatment stops.
Not at all. The true picture evolves over a lifetime, sometimes generations. It underscores why we need continuous monitoring, long-term studies, and constant updates to our understanding. The risk assessment is never truly finished.
That's a really powerful perspective, a reminder that our decisions today have ripples long into the future. Thank you for guiding us through all this complexity.
My pleasure.
And thank you, our listener, for taking this deep dive with us today.